Good afternoon. Welcome to the last webinar co-organized by the European Vasculitis Society and the ERN-RITA for the Vasculitis Awareness Month. My name is Maria Cid. I am a senior consultant at Hospital Clinic, Barcelona, Spain. And my co-chair is Beatriz Sánchez Alamo, who is a consultant nephrologist at the Hospital Alcorcón in Madrid. And she is conducting long-term follow-up of EUVAS studies. The webinar today focuses on innovative therapies for vasculitis. And each speaker has 20-25 minutes, and then we will have at the end a 10 minutes questions and answer period. If you have a question, please write your question in the chat, mark it with a question mark, and we will moderate this discussion. It is my pleasure to introduce the first speaker, which is Professor Bernhard Hellmich. He is head of the Department of Internal Medicine, Nephrology, Pulmonology, Rheumatology at the University of Tübingen. And he has coordinated the current EULAR recommendations for the management of vasculitis. So thank you very much, Professor Hellmich, for being here with us today.
Yeah, thank you, Maria, for the kind introduction, and hello to everybody. So it's a pleasure to be here today. And yeah, when David and I thought about planning this webinar, we thought it would be perhaps the best to focus on a disease group of ANCA-associated vasculitides in order not to become too generic. And so I will kick off and talk about why we need innovative treatments for these diseases, and how next generation B-cell targeted therapy may help. And then David will continue with other targeted therapies that may help to improve the treatment of our patients in the future. These are my disclosures. And as some of you within the RITA network may not be too familiar with these diseases, I will start with a short introduction. So the ANCA-associated vasculitides are GPA, MPA, and EGPA. For this talk today, we will focus on GPA and MPA because they share many clinical features and have a similar approach to therapy. Although they have some differences, they have a different genetic background and different seromarkers, so PR3 anchor for GPA and MPO anchor for MPA. But treatment is quite similar. And as we have heard, there are quite good guidelines today for the management of ANCA-associated vasculitides. So in Europe, we have the EULAR recommendations, but there are many others as well in the United States, in Japan, and other countries in Europe and outside of Europe. And I will show you just briefly as a start what's the current state of therapy and what are the perhaps pitfalls of these therapies that require improvement. So when we have a patient with active GPA or MPA who has organ-life or life-threatening disease, which is a majority of patients, consensus is to start with either rituximab or cyclophosphamide. We prefer rituximab for relapsing disease. We combine this with high-dose glucocorticoids or with avacopan, a C5 receptor antagonist, which can replace steroids to some extent. And then we taper the glucocorticoids to a threshold of around 5 milligrams after 4 to 5 months. In patients with very severe renal involvement and a creatinine above 3 milligrams per deciliter, you also can consider the use of additional plasma exchange. In patients who have no organ or life-threatening disease, we usually start with rituximab as well. Methotrexate or mycophenolate can be an alternative. In some European countries, methotrexate or MMF is still preferred, but the consensus is that rituximab is very effective in this population as well. The new standard for glucocorticoid taper is the reduced glucocorticoid taper regimen, as it has been investigated in the PAXIVA study, the largest prospective trial in ANCA-vasculitis that has been ever conducted, and that showed a non-inferiority towards efficacy, but a superiority towards the development of severe infections. And so this is the new standard, and all societies agree that this is the best way to taper glucocorticoids according to this protocol. For maintenance of remission, rituximab is the new standard. We give it usually for a period of 24 to 48 months and then continue rituximab in case if risk factors are present that indicate that further relapses may come down the line. If the patient is on steroids, the steroids are tapered slowly and should be stopped at some point. And also avacopan, which has been tested for only 1 year so far, is usually tested after this period of 1 year is over. Some societies recommend rituximab just for severe disease, like in South America or in the United States. The KDIGO, the Nephrology Society, also recommends azathioprine as an equal alternative to rituximab. So books are not closed here, but data for what we felt in Europe are really superior for rituximab in the inhibition of relapses. Consensus on the duration of treatment is not as strong. So as you can see from this graph, Europe recommends the duration of 24 to 48 months for new onset patients, but also recommends longer treatment in relapsing patients. The data there are not so strong at this point, so some societies have different approaches. For example, the ACR recommends to stratify the treatment duration just on the patient preferences and risk factors. So how do we stand with these current therapies? So the disease burden of AAV is characterized first with active vasculitis, which can induce organ damage. We usually start immunosuppressive therapy aggressively right at the beginning. This may help to control the vasculitis, but also predisposes the patients to infections and other drug-related side effects, which altogether lead to problems in the patient with increased mortality, with an impairment of quality of life, with organ dysfunction, and also other symptoms that may reside. So let's have a little bit closer look. So in terms of mortality, unfortunately, AAV is still associated with an increased mortality. This is a nice study from one of our co-chairs, Beatriz Sanchez-Alamo, published just 2 years ago from the EUVAS cohort that showed that in long-term follow-up, after 1 year, mortality is exceeded by 14%. And the longer the follow-up is, the worse it gets. So after 15 years, we have 29% excess mortality in AAV patients compared to the general population. And this is mainly due to infections, but also cardiovascular disease, and in the later patients, malignancy. A second important burden is, of course, relapse. So patients with AAV usually relapse if you don't give any maintenance therapy. And over the years, we have identified a couple of risk factors for relapses that includes baseline factors like diagnosis of GPA, PS3 anchor positivity, higher serum creatinine, and after relapse, after diagnosis, persistence anchor positivity or a rise in anchor, and also treatment-associated factors like a lower induction therapy with cyclophosphamide or an early withdrawal of immunosuppressive therapy. However, rituximab has helped to lower the relapse rates down the line compared to azathioprine. We have 2 trials showing this, the main RITA trial and the rituximab trial. So rituximab seems to be the new standard. But how good is it really? So let's have a closer look at the data. These are trials that have used prospectively rituximab for maintenance of remission. And when we look at major relapse rates in the last column, this looks pretty good. So major relapse rates are pretty low, between 5% and 6%, but there are still minor relapses around 5 to 25%, depending on the duration of observation. So rituximab is quite good as long as we give it, but when we stop rituximab, problems come again. So these are all trial data from studies that have stopped rituximab prospectively at one point, and the numbers are pretty equal. So you can get a relapse rate of 35 to 47%, depending on the duration of observation. And also major relapse rates, depending on the cohort that was studied and the duration of observation, ranges from 15 to 51%. So these diseases are certainly not cured when you stop rituximab at one point. The hope was if we give rituximab for a longer period, we may induce some kind of healing, but this didn't turn out to become true. So if we look at all these data from RAVE, from main-RITSN 1 to 3, or rituximab, which had different durations of therapy, and you can see at the cutoff point when rituximab is stopped, there is some time where things do well, and then afterwards patients are relapsing again. So rituximab is certainly not a cure for the disease, and so the duration of therapy is a matter of debate. Organ damage is also an issue where we should get better. So we have this study also from the EUVAS trials that looked at damage a little bit more closely, and you can see that there's quite a lot of damage in patients with ANCA-associated vasculitis, especially in the renal department, but also in the ENT department, that really is bothersome for patients. There are also damage that is related to therapy, especially glucocorticoid, and you can see that the duration of glucocorticoids is often more than 2 or 3 years, and patients continue this therapy for relapses or in some cases also for maintenance. Infections are still a problem. So on maintenance therapy with rituximab, the rate of serious infections on maintenance therapy is between 10 to 20%. And these infections may increase down the line. And we can see that it's still a major cause of death even after 5 years from diagnosis. Here again, a paper from Beatrice we have seen the data on mortality, and the most driving force is in fact infection. This is particularly problematic during the induction phase, where almost 50% of all deaths are contributed to infection. But you can see even after more than 5 years, 20% of all deaths are attributed to infection. So this is really a problem where we should get better. Continued use of rituximab can be associated with hypogammaglobulinemia. And the problems start if you continue it for more than 2 years. And this study also showed that the probability of a significant hypogammaglobulinemia increases with prior cyclophosphamide exposure, in addition to rituximab, also to an extended glucocorticoid use and female sex and a lower immunoglobulin nadir. So how can we get better here? So the pathogenesis of AAV has been extensively studied. And although we have 2 diseases with a different genetic background, the pathogenetic cascade is pretty similar. So we have, based on the genetic factors, environmental factors that stimulate the immune system, that activate antigen-presenting cells, which then activate T cells and also B cells. And the neutrophil components like proteinase 3 and myovyl peroxidase are expressed on the cell surface. And then finally, neutrophils are activated by these T cells and also by the antibodies, by the PR3 anchor, which are produced by these B cells and plasma cells, and lead to small vessel vasculitis and in GPA also granulomatous inflammation. So why does rituximab fail in some patients? So we have seen that in the induction trials that up to 20% of patients don't get into full remission, and many relapse after rituximab is stopped. And there are some anecdotal experiences, some mostly case reports and small series that show that autoreactive B cells may persist in lymphoid tissues and also in other tissues despite peripheral B cell depletion. So if we measure B cells in the blood and hope to have a complete B cell depletion, there may still be B cells in the tissue that may the reservoirs for ANCA production, and that may drive disease flares. And we have seen this in different types of tissue, including bone marrow, in granulomatous lesions, in the lung, and also in the eye. So these B cells could be a target for a more intense B cell depletion, and there are different ways to approach this. So we have learned a lot from oncology and also from other autoimmune diseases. So today we have other more intense B cell blocking antibodies like obinutuzumab, a next generation B cell blocking agent. We have CD33 agents like daratumab. We have the potential to deplete B cells also by cells, by CAR T cells. which has been turned out to be very successful in lupus, as we know so far. They are bispecific T-cell engaging antibodies that could help, and perhaps in the future also antigen-specific approaches with antigen-specific CAR T cells. So what do we know so far? So obinutuzumab may be one of the first agents that could help in this matter. It's a humanized type 2 anti-CD20 monoclonal antibody, and compared to rituximab, while it has a lower complement-dependent cytotoxicity, it has a greater antibody-dependent cellular cytotoxicity, and it is superior to rituximab in oncology for treating lymphocytic leukemia and follicular lymphoma, and it's approved for these diseases in these indications. Also, there was a very recent study, a phase 2 trial for lupus nephritis, where also obinutuzumab reached the primary endpoint. So could this be something for AAV? We have some small case series so far. So there was one of the first papers from, I think, Peter Merkel's group that looked at 3 patients that had anaphylactic reactions to rituximab and now had a relapsing active disease again. And these 3 patients were treated with obinutuzumab, and all these patients got into remission and had no relapse while being on maintenance therapy. And importantly, all became and stayed ANCA negative, which shows the strong B-cell depleting potential of this medication. Another series was just recently published from the Netherlands in 6 patients with MPA or GPA, of which all had previously anaphylactic reactions to rituximab and now needed active therapy again. Induction of remission was successful in 4 of 4 patients who needed the therapy for induction of remission. 2 others received it just for maintenance. And there was 1 relapse 2 years after stopping obinutuzumab, but no relapses while the therapy was continued. There were no serious infections in this series. And as you can see, the time to B-cell recovery after administration of obinutuzumab was longer, with around 14 months compared to rituximab, where it was between 6 to 8 months. All patients had an ANCA zero conversion, so you can see here nicely that ANCA became negative and stayed negative in all patients, which was not the case in rituximab that was given previously. In our own cohort, we have found 5 patients with treatment with obinutuzumab. And of these patients, only 1 had a rituximab allergy before. The other patients had relapsing or refractory disease despite therapy with induction therapy with rituximab or cyclophosphamide. You can see that these patients primarily had refractory ENT and eye manifestations, so conductive hearing loss, progressive nasal saddle nose deformity, increased scleritis and arthritis and neuropathy in 1 patient, refractory scleritis in another patient, sinusitis and mastoiditis in 1 patient, and also sinusitis with bony destruction and optic nerve involvement in the 5th patients. They all received induction therapy with obinutuzumab, and some of them also maintenance therapy. So we have 2 patients that have been treated for 3 and 4 years now. So all 5 patients are in remission. All 5 patients became ANCA negative. At the time obinutuzumab was started, 4 of 5 were highly positive for PS3 ANCA despite previous therapy. So this also shows that obinutuzumab may be a promising therapy in AAV in the future. And there are right now 3 clinical trials enrolling for obinutuzumab. One is the EUVAS trial in the UK, where obinutuzumab is given compared to rituximab. And the primary outcomes are not clinical, but mechanistically. So they look at CD19 B cells in the tissue and also, of course, in the blood at baseline and at week 26. And this study is still recruiting. There is another study, the OB1 study, that is looking primarily at PR3 anchor serum conversion and completing of prednisone. This study seems not to recruit yet. And another study in the United States, according to clinicaltrials.gov, has been terminated by the sponsor so far. What other approaches could we have? So belimumab, which you know is a antibody that is approved for lupus, and is also a B cell activating blocker, a BEF antagonist. This has been studied in a prospective trial in conjunction with azathioprine compared to azathioprine only for maintenance of remission. In this trial, there was no difference between belimumab patients and placebo patients, so relapse rates were similar. But there was an interesting observation that those patients who had received rituximab for induction of remission, none of these patients developed a relapse. So there could be a role for a combined therapy with giving rituximab first and then belimumab afterwards to reduce the probability of relapse. And this concept is now being studied in the COMBIVAS trial. It's a randomized trial of rituximab and belimumab sequential therapy versus just rituximab. So patients after screening receive 2 pulses of rituximab and then are randomized to receive belimumab subcutaneously or placebo belimumab. The study goes for 1 year. And we'll have a follow-up phase of another 24 months. The primary endpoint, because it's a small study, is again time to PR3 anchor negativity, so a biomarker endpoint. So now let's move to the more stronger agents. I talked about daratumab, a CD38 agent. It's expressed on lymphocytes, macrophages, dendritic cells, and other cells. And it depletes plasmablasts and plasma cells. So it's, as you can see here on the right, it's a much deeper B cell lineage depleting agent, and it's approved for multiple myeloma. And we have some positive experiences in a series of different autoimmune diseases where overall a positive experience was made. And there was now a recent report of the use of daratumab in 3 patients who had severe allergic reactions to rituximab. And all these 3 patients went into remission successfully with daratumab. There were no relapses on maintenance therapy and all became ANCA negative. So also this agent could become a candidate for future therapies in AAV. As to my knowledge, there are no prospective studies on this agent currently recruiting. So by more intense B-cell blocking therapies may work in AAV. Of course, the cellular-based therapies could be of interest. We have heard about the CAR T-cell therapy in lupus and other collagen vascular diseases. So should this work in AAV? And as you know, the principle of CAR T-cell therapy is to generate T-cells from patients and to enrich them to add the CAR T-cell antibody, and then to do a lymphodepletion in the patient, then to enrich these CAR T cells, give them back to the patient, and these CAR T cells then move on and destroy the persisting B cells. And this seems, at least in mice, so there is a nice animal model from Adrian Schreiber's group in Berlin, and they have used CAR T-cell therapy in MPO ANCA-positive glomerulonephritis. And these CAR T cells work. They deplete the peripheral B cells not only in the blood, but also in different organs, which is important. So in the kidneys, in the lymph nodes, in the bone marrow. And there is a nice expansion of these CAR T cells in these tissues as well. They deplete plasmablasts in these organs, in the spleen and in the kidney. And of course, they work on the disease. So they protect the anti-MPO-induced mice from developing glomerulonephritis. So you can see there is a nice blockade of crescents development and necrosis. And this is accompanied by a decrease in MPO anchor. So can this work in men? There is a single case report also from Berlin in a 52-year-old male patient with refractory GPA who had previous therapies, including cyclophosphamide, rituximab, MMF, and so on. He now presented with a relapse with pulmonary disease, arthritis, these symptoms, and fever while being on maintenance therapy with rituximab. He was highly PR3 anchor positive. And despite rituximab and avacopan, he was still active. And then he was transferred to CAR T cell therapy. He had a nice expansion of CAR T cells. He had as you would expect, a depletion of B cells and also a reduction of PR3 anchor. And the clinical outcome was favorable. So he got into remission. He had some constant minor lung nodules, but otherwise no disease activity. He had a cytokine release syndrome that was successfully treated with tocilizumab and a neutropenia that was treated with G-CSF. And so this seems to work in men. And there are a couple of trials now starting to recruit for CAR T-cell therapy, one in Germany, one in Asia, and one in the United States, smaller trials. So we can see that there is interest in these CAR-based therapies in AFE, and it could be really a promising development in the future. So now to conclude and to move on to David's talk, I would like to sum up that the outcome of AAV has improved with the introduction of rituximab and reduced dose glucocorticoids. We now have nice treatment guidelines, how we can manage our patients, but there are still challenges that remain. Mortality is still increased. Infections are a big problem for 1/4 of the patients. They are the cause of death. Relapse rates with rituximab are still too high. When we stop the therapy, we have still a risk for end organ damage, including kidney failure. We have made good progress, but no cure, so we really need safer and more effective therapies. And so the ongoing developments of next generation B-cell targeted therapies that include obinutuzumab, bispecific antibodies, belimumab, CAR T cells are really very welcome. And there are also other targets on the horizon that David will show you in the next half hour. And now I'd like to conclude, and I'm happy to take your questions. Thank you.
Thank you. Thank you very much. Sorry. Thank you very much, Dr. Hellmich, for your comprehensive and nice presentation. So,
now it's my honor and pleasure to introduce our second speaker, Professor David Jayne. Professor Jayne is a globally recognized expert on the field of autoimmune diseases. He is the director of the Vasculitis and Lupus Service at Addenbrooke's Hospital, professor at the University of Cambridge, and currently serves as the president of the EUVAS. Professor Jayne, the stage is yours.
Beatrice, thank you for the introduction. Can you see my slides okay? Can you see my slides?
Yeah, perfect.
Good. Okay, thanks. So I'm going to discuss largely complement inhibition after Bernhard's talk about the introduction to vasculitis therapy and B-cell targeted therapies. These are my disclosures. One of the problems with B-cell targeted therapies is they do not work very quickly, and we require rapid onset of anti-inflammatory drugs in order to control vasculitic activity, which is driving damage. This study was conducted on quite old EUVAS trials and shows the value of obtaining an early remission by 3 months and staying in remission for reducing the incidence of mortality and end-stage renal disease. And this is a remission by 3 months. Ideally, we'd like to have patients in remission much more quickly. And the mainstay of our anti-inflammatory approach currently is high-dose steroids, which are incompletely effective and toxic. So why target complement, and why should we consider complement as an important pathway in ANCA-associated vasculitis when it has been defined histologically as a poorly immune disease, meaning few or no immune deposits detectable on biopsies, typical kidney biopsies? Well, actually, this is all a bit misleading. And there's quite a lot of data suggesting complement activation is important in the pathogenesis of ANCA-associated vasculitis. Firstly, studies outside the body, in vitro studies, have shown that complement can work with ANCA to activate neutrophils. We know neutrophils require priming, and this can be done with pro-inflammatory cytokines such as IL-1 or TNF, but it can also be done with C5a. And this graph shows that with increasing doses of C5a, so you get more neutrophil activation when you cultivate these cells with ANCA. Also, we know that when neutrophils activate in ANCA-associated vasculitis, they release neutrophil microparticles along with neutrophil nets. And these substances contain further complement convertases, which are able to split complement and release more C3a and C5a. And this then sets up a positive feedback loop with neutrophil chemoattraction, particularly as a result of C5a, then neutrophil activation with C5a and ANCA, and then further neutrophil activation. And this is driving the damage to endothelial cells and ultimately tissue damage. A key experiment was performed in mice in which an MPO-ANCA vasculitis could be induced. And it was shown that the C5a receptor was critical to the induction of vasculitis. The panel on the right shows a glomerulus with a large crescent in an animal with an intact C5a receptor, and on the left shows no disease in animals in whom the C5a receptor has been knocked out. The right-hand graph looks at the crescent score, so a similar parameter, and shows that if you give the anti-MPO with an inhibitor of C5a, this is C6168, now called avacopan, this completely stopped the appearance of glomerular crescents. Further studies with this model showed that if you knocked out the second C5a receptor, this is called C5L2, the animals actually got worse, suggesting this receptor might have a regulatory function. And if you tried to knock out the classical complement pathway, here knocking out C6, there was no effect on the disease. So the conclusion from these experiments was, at least in the animal model, it was exquisitely sensitive to an intact C5a receptor and alternative complement pathway activation. This then led to the development of avacopan, which is an oral C5a receptor inhibitor, which is given twice daily. And I emphasize this works quite low down in the complement cascade. It does not affect C5b signaling, which is important for prevention of meningitis and other bacterial infections, and does not affect C3. And the hope was that avacopan would be safe and would not have infective complications. The pivotal study, the phase 3 trial that led to the approval of avacopan, was the Advocate trial. And in this study, avacopan was compared to a conventional reducing dose of steroids, all patients receiving a background of either rituximab or cyclophosphamide. At 26 weeks, there was no difference. So steroids were equally effective to avacopan at 26 weeks. But at 52 weeks, there was superiority of avacopan. And the end point I'm showing you here is sustained remission. That is, patients achieving remission by 6 months and sustaining the remission without the need for any steroid through to 12 months. And there were 12.5% more patients in the avacopan group achieving this endpoint than with the steroid group. But when we come to consider using avacopan in the clinic, we need to consider key secondary endpoints. So avacopan reduced relapse rate, which was the upper left panel. It reduced steroid toxicity using the subjective model, the glucocorticoid toxicity index. It improved recovery of kidney function for those patients presenting with acute kidney injury. And there were quite marked improvements in quality of life. So here we're looking at results with the SF36, and this is the physical component on the left and the mental components on the right. And in this score, the higher the better, and the red bars are showing greater recovery with avacopan than steroids. So these results give you some guidance as the type of patients who are going to benefit most from avacopan, those in whom you want to avoid steroids, those with a high relapse risk, and those with low GFR. We now have a wealth of real-world data becoming available, and this is how avacopan is being used in the UK, predominantly for steroid sparing, quite often for severe nephritis, often the combination, steroid sparing and severe nephritis, and we're beginning to use it for these refractory patients who were not actually studied in the Advocate trial. And some initial results from Lucy Francis working in Cambridge shows that with real-world data compared to historic controls, we are beginning to see a similar impact on GFR recovery that we observed within the Advocate trial. And we think the most plausible explanation for this is that there is earlier control of inflammation within the kidney by avacopan, and this is reflected by more rapid reductions in proteinuria. And then later, we're seeing the better recovery of kidney function, but that remains a hypothesis. So we have avacopan in the clinic. We have some idea of the sort of patients we want to use avacopan in, but in terms of the future, we have a number of questions around further complement inhibition approaches. The first is, what about indications that were not studied in Advocate? That is the very low GFR patients, GFR less than 15 or dialysis requiring. And what about patients with severe lung hemorrhage who are not studied? What about the role of avacopan for long-term remission? We only have 12 months data. We don't have data for several years. And should we follow the Advocate approach, which is to give no steroid with avacopan, or is there actually a value of giving avacopan together with some steroid? These are unanswered questions. When considering alternative complement inhibitors, the question is what to target. Do you go after the alternative pathway as avacopan, but do you go more broadly, for example, to try and target C5b? And we do have evidence in humans that the C5b axis is important. Do you try and target cofactors, either amplifying or reducing alternative pathway activation, that's cofactors B, D, and H, or do you go after the classical pathway? These are all unanswered questions. And then a big problem we have is about biomarkers. We do not know how to dose complement inhibitors. And what we really want to know is what's the dose that gives us optimal tissue inhibition? And we have currently no guidance as to whether the dose we're giving is correct. And of course, this is important because we want to balance optimal tissue inhibition with safety and infective risk. And then, of course, there is the mechanism. What is a complement inhibition doing? So we originally introduced it to try to target neutrophil activation, as discussed in an earlier slide. But there is some evidence that complement inhibition may impact other pathways, such as T cells and B cells, or may impact fibrosis and tissue repair. And these are questions being addressed in current studies. So we have a number of complement inhibitors in development for immunologically mediated disease. And I'd particularly like to highlight, under the alternative complement pathway, drugs that are targeting factor B, such as iptacopan, or targeting factor D. Both of these are cofactors that amplify or permit activation of the complement convertases. And then we have alternative drugs working lower down at the C5 level. You'll be familiar with eculizumab, Solaris, which has been available for many years, but is very, very expensive. And we have alternative drugs which target C5a, such as vilobelimab. Now, the only clinical trial currently of all of these agents in ANCA-associated vasculitis is with iptacopan. And iptacopan is an oral inhibitor of factor B, and it is licensed for paroxysmal nocturnal hemoglobinuria, where it is at least as effective as eculizumab. And we wait to see what the effects of iptacopan and ANCA-associated vasculitis are going to be. We do anticipate other complement inhibitor studies will start over the next 12 months. Evidence from humans of alternative complement pathway activation comes from this study from the VCRC network in North America, where they have looked at changes in plasma and urine BA levels. So this is activated factor B. And they've shown that in refractory patients, level tends to be slightly higher during remission and then rise further prior to relapse. But this is particularly marked in the urine, where you see a marked rise in factor BA levels at the time of relapse. Evidence for the classical pathway activation comes from this German study, which found deposition of complement C4 in the blood vessels and some of the glomeruli of patients with ANCA-associated vasculitis. And C4 is a component of the classical pathway. This Japanese study was addressing the hypothesis that there might be an immune complex mediated pathogenesis of ANCA-associated vasculitis. And they took patients with high affinity MPO ANCA, that is, these patients with high affinity on this inhibition assay, and they demonstrated that they were more likely to have alternative complement pathway activation, C5a, and C5b activation, and C4 deposition, and the deposition of the terminal attack complex. This is what you would expect to see with antibody-containing immune complexes driving the complement activation. So this may also be a component in the human disease. That's all I'm going to say about complement targeting. I'm now just going to touch on two other areas which are beginning to attract interest therapeutically. One is targeting the neutrophil directly, and cathepsin C inhibitors are now in medicine for particularly chronic pulmonary disease such as bronchiectasis. And cathepsin C is a serine protease that is important in neutrophils generating neutrophil nets and in neutrophil activation. And this Japanese study took an MPO ANCA model, murine model of vasculitis, and showed that with a cathepsin C inhibitor, they could reduce lung hemorrhage and they could reduce necrotic glomerular lesions. So this is evidence that cathepsin C inhibition, which is quite a simple and safe thing to do, might improve or reduce the neutrophil targeted damage. The last area to consider is targeting fibrosis. Now, when you biopsy a patient with ANCA-associated vasculitis, typically you find lesions of varying ages, some which are quite fresh and cellular and some which are quite fibrotic. And we've long thought that inflammation drives fibrosis, and persistent inflammation in vasculitis will drive fibrosis and loss of organ function in the kidney, which is then irreversible. So the question rises, if you can block fibrosis from occurring, does that mean that the kidney is better able to recover from acute inflammation with better resulting organ function? And a target in development is monoclonal antibodies targeting claudin-1, which is a molecule expressed, which is in health, binds proximal epithelial cells together, but is hyperexpressed in disease and drives fibrosis. And there is a current trial of a drug called lixudibart, which is a monoclonal antibody which blocks claudin-1. There's a trial in ANCA-associated vasculitis. And there has been a press release from Alentis, who are driving this trial, showing improvements in proteinuria and GFR recovery in ANCA-associated vasculitis patients treated with lixudibart. So in summary, our patients unfortunately continue to suffer a chronic relapsing disease with high levels of chronic morbidity. And although current treatment is well evidence-based from the trials, many of the trials that Bernhard described in his talk, there is the opportunity to try and improve disease control and achieve disease control more quickly. Emerging therapies are focusing either on B-cell target depletion, on cytokine inhibition reprogramming, but really what I've tried to discuss in this talk particularly has been the role for complement inhibitors and the opportunity for new complement inhibitors, and then I've touched on neutrophils and fibrosis. Thank you for your attention.
Thank you, David, for such a nice talk. I think, Maria, we are entering now the questions session.
Yes. There is a question in the chat by Dr. Elkatep. It's for Dr. Hellmich. And this question, Dr. Elkatep is worried about whether a deeper B-cell depletion, as with new agents, will lead to higher levels of hypoglobulinemia. And so what's weighting more, B-cell depletion or preserving antibody function? And he always wonders about if this imbalance may be of concern in the pathophysiology, because T cells are also involved, and whether B-cell depletion alone would work. So this is the question, complex question.
Yeah, thank you. That's a good question. Of course, we are concerned about the hypergammaglobulinemia, but I think that's mostly due to the peripheral many B cells that are depleted. And as we have seen from extended use of rituximab, the problem increases with the extended use of this medication for several years. And so with a more deeper depleting therapies, we want to reach two goals. The first goal is, of course, to get patients in remission who cannot get into remission with rituximab, which is quite rare, but which happens. The second is, of course, to have an alternative to rituximab in patients who can tolerate it. But the holy grail is, of course, the idea to heal the disease. And that is something that we hope to have seen in other diseases. So there is some hope in the lupus observations. They are not so long, but in these observations, we have seen that CAR T-cell therapy was able to keep patients in remission without therapy. That is something we have not so far seen in ANCA-associated vasculitis. So if we could get to that point that we can really cure the disease, there would be no risk of hypergammaglobulinemia down the line. And so if we could really stop this repeated use of rituximab, that would be a fantastic thing. If this will ever happen, we don't know. We have to wait for the clinical trials. We had hoped to have a similar result with rituximab. So when the first trials were designed, for example, the RAVE trial, therapy was stopped after reduction, but then we saw all the relapses down the line. So this is really not happening. So to shorten the exposure to these agents would really help to get rid of these problems with hypogammaglobulinemia. And the second part of the question addressed T cells. Of course, T cells are involved in the pathogenesis, but so far the approaches to target T cells directly in AAV have not led to a approved therapy. So very recently we had the study on abatacept for maintenance of remission, and it was unfortunately a negative trial, so it did not seem to help. So it's certainly an area of investigation, but nothing that really helps us today. Thanks.
Thank you, Bernhard. We invite you to keep posting your questions. We have another question for the chat. It is
I think you're frozen, Beatrice. We cannot hear you. Maria, you should turn on your microphone. We cannot hear. Thanks.
While Beatrice is frozen, maybe I think she's back. She's back. Yeah, okay.
I'm back. I'm really sorry. I was saying that we have another question. It's about the primary pathogenic role of B cells in ANCA-associated vasculitis. And the question is about if it's the B cells' role for presenting antigens or their antibody-producing function that drives the disease, and how can it be possible that rituximab work if it doesn't target plasma cells?
Yeah, thanks. That's a great question as well. So probably both functions play a role. So we know that rituximab works as long as we give it. So I think there is clear efficacy shown in both induction trials and also in the maintenance trials. So targeting these CD20 positive B cells seems to work. But we see some patients fail therapy, and if this is due to the regulatory function of the remaining cells, or to these cells which are really in the tissue, which we don't get with rituximab, that's an open question. So I've not seen convincing study yet addressing these questions. And so we will have to see how these new approaches really work. And I hope these studies will be accompanied by mechanistic studies. Some of them already have mechanistic endpoints. So we will certainly learn a little bit more about B-cell therapy and ALV when these trials are completed, like on obinutuzumab or belimumab. And so for now, it's just speculation in my view. I don't know, David, if you have another thought on this.
I certainly think that the newer agents are inspiring more biomarker work, particularly tissue biomarkers. And I think a better understanding of what's happening in the tissue to do with B cells, T cells, and their interaction is going to give us an insight into some of these questions. And I think really what we've learned is that measuring the blood is not telling us really what we want to know.
We have another question in the chat from Dr. Visognik. And it's a question regarding Dr. Hellmich's talk. And Dr. Hellmich's comment that rituximab does not target autoreactive B cells in peripheral and lymphoid tissues. And could you elaborate a little bit more about how current or upcoming therapies will target these autoreactive B cells in tissue?
Yes, so I think the hope is that when we use agents which have a broader target like daratumab, that then we can fill this gap. So that would be the idea, to give an agent that has a broader mode of action, like the CD38 agent. But so far we only have experience from 3 patients, from 3 case studies, no prospective trials. But that is certainly something that should be closer investigated. And these were just clinical observations without any mechanistic studies, so I don't have a good answer on that for you now.
I would add to that I think rituximab does have an effect on tissue, but I think the effect is mild and transient. So you do see, for example, a reduction in naive B cells in tissue. You don't see much reduction in switch memory B cells. But I think rituximab works for a period of time and then stops working. So I think it is having a transient effect. But I think, as Bernhard said, the current hypothesis is if you can really clear out those B cells, and I think this was shown in that CAR-T patient, you can completely, then you may, as it were, completely reset the system. But it's going to take a number of years for us to know whether this is true.
I would like to ask you, Bernhard, since you are an expert in obinutuzumab, if you could please elaborate a little bit more about your experience using this drug, or side effects, and how has this drug worked in your patients?
Yeah, thank you. So far in my hospital, we have treated 5 patients with obinutuzumab, and the experience was quite good. So these were all refractory patients, of which only 1 had an allergy to rituximab. So the other 4 were really patients where we had used everything else, and these patients had problematic, primarily ENT and eye manifestations. They really, the treatment calmed down the disease. So we feel it's a quite good treatment, a quite safe treatment. But I can report one interesting note that there was one patient who presented with with pulmonary infiltrates again, so ground glass opacities, and so we were unsure what it was, and then we finally did a BAL. And what we found that this was a non-cleared COVID infection. So the symptoms have been there for a couple of weeks. And so we gave her antiviral therapy intravenously, and she cleared. So the more deeper B cell depletion really seems to have an effect on infections as well. That's just one case, but it is something we would need we have to consider if we give this stronger agent that certain side effects regarding infections may come up again. So that's why we need prospective trials in this population and not just case series like the one we have in our hospital. Thank you.
Maria, we cannot hear you.
One of the advantages of CAR T cell therapy seems to be that by targeting CD19, it also depletes plasmablasts in addition to B cells. So, there are any anti-CD19 antibody in the pipeline for ANCA-associated vasculitis, or why this had not been used, in addition to CAR T therapy?
Yeah, I'm not aware of any CD19 antibodies so far. So there must be a reason, but I'm not sure why it hasn't been used.
I think we've actually considered anti-CD19s for a long time. We've also considered anti-CD20s for a long time, alternative anti-CD20s to rituximab. The reality is that you need pharmaceutical company collaboration to a degree in drug development, and there's been no real interest in those companies with CD19s to do that. And in a way, it's just chance that CD19 is the target used in non-Hodgkin's lymphoma for CAR T cells. So that's what's available. And I think it's not actually that we've considered targeting CD19 in ANCA-associated vasculitis. But as you say, it may well be a better target, an anti-CD19 monoclonals. And I think, Bernhard, on your diagram and your list, you had anti-CD19 monoclonals. I think they would be well worth trying.
Yeah.
Good. I think that unfortunately time flies. We are approaching the end of this webinar. On behalf of the ERN-RITA and EUVAS, we would like to extend our sincere thanks to our panelists for their excellent contributions and the engaging discussion we have followed today. Thank you as well to everyone who has joined us today. Before you leave, we kindly invite you to share your feedback by completing the short survey that will appear once this webinar is closed. We hope to see you all again soon, and thanks a lot for attending today.
Thank you.
Thank you. Bye-bye. Have a good afternoon.
Bye. Bye.